presenter, Dr. Leslie McClure. Dr. McClure is a professor in the Department of Biostatistics here in the School of Public Health. She's also head of the section of research methods in clinical trials. Dr. McClure's research focuses on the design and analyses of randomized clinical trials. She also does work on environmental epidemiology. So the title of Dr. McClure's lecture is The Design of Clinical Trials, Data and Safety Monitoring Boards. Dr. McClure.
Thank you for having me, and I would also encourage you to scoot up. I promise I don't bite or throw things very often. This is going to be kind of like a talk in two parts today. So the first part's going to be about clinical trials, and I know you've had a lot of background in clinical trials already, so it's going to be a little bit different format than just me standing up here lecturing. I'm going to expect some audience participation, so if you need some coffee for that, then go get that now. And then we'll have, I understand there's a break in the middle usually, and then we'll have a little break, and then I'll talk about data and safety monitoring boards and their role in clinical trials, and that will be a little, well, I don't want to bias you, so that will just be more of a regular lecture format, maybe not quite as fun, for me at least. Okay, so today there's several learning objectives. The first is to just review concepts in study design. So I know that Dr. Oster has come and talked to you about clinical trials and study design and different types of data, and I know that Dr. Neighbors and Glasser have also come and talked to you about clinical trials, so I didn't want to reiterate everything you should have already heard, but I do want to review the key features that are pertinent to what we're going to talk about today. Then we're going to examine real-world examples of clinical trials. So I have 3 papers I've pulled from the literature. 2 I'm not as familiar with. They're just current topics. One is one that I'm an author on. We're going to go through and identify some of the key features of the study and look and see what the people actually did. So what we think they should have done, does that match with what they actually did? Then, as I mentioned, we'll switch gears and I'll talk more about data safety monitoring boards, or Dsmbs, in clinical trials, describe the role of Dsmbs, what a typical Dsmb meeting might be like, and then some of the statistical issues that are associated with Dsmb meetings. So why am I, as a statistician, talking about Dsmbs, since it's really a safety monitoring and I'm not a clinician? Okay, so I'm going to go through quickly some of the concepts in study design that you've already covered, just to make sure that we're all on the same page. So the hypothesis is the conjecture, the supposition, or what motivates the research. What's the question that you're aiming to answer? In clinical trials, we purport that we can do our clinical trial because there's this idea of equipoise. There's no predetermined outcome. So I actually am teaching an advanced clinical trials class right now in our department, and I spent a whole lecture talking about ethics and this idea of equipoise. And it doesn't mean that each of you, as an investigator on the trial or as a clinician, believes that there's no answer, but it really means that in the medical community as a whole, there's no single answer to that question. A hypothesis needs to be stated in a way that allows evaluation, both clinically but also with appropriate statistical techniques. So as a collaborator, I often am working with clinicians, and they often come to me and say, here are my aims, please help me write the analysis plan. But oftentimes the aims aren't framed in a way that lend themselves easily to an analysis. So there's a lot of back and forth and discussion so that the hypotheses or aims are framed in a way that makes them testable. And they must be able to be supported or refuted through experimentation or observation. So we have to be able to test these with real data. The outcome, hopefully you're all familiar with what an outcome is. It's the variable being tested in your experiment. So this has to be measurable. There has to be some way to quantify what you're trying to measure. It has to be testable. There must be a valid measure, or it must be valid for testing the underlying hypothesis of interest. So the outcome you choose must be concordant with the hypothesis that you're testing. And it can take several forms. And again, I know Dr. Oster went through this in a lot more detail. You can have a continuous outcome, such as systolic blood pressure or cholesterol or any other number of biomarkers, quality of life measures. You can have a categorical or ordinal outcome, such as the degree of stroke severity, for instance. Or you can have categorical or nominal outcome that doesn't have any ordering to it but has different categories. So we use statistical methods to test our hypotheses, and there are certain features of statistical tests that we have to set ahead of time in order to do so. So the first is if you have a one-sided versus two-sided hypothesis. So this is a very, oftentimes the question is one-sided. People often think that the new treatment will be better than the other. But we almost always test two-sided hypotheses, even though we have one-sided questions, because we don't know. In fact, I review grants for a clinical trial study section, and I was working on one last night where previous reviews were really upset that in this phase 3 trial, the investigators wanted to use a one-sided test. And so we have to think about, is our question one-sided, but will our test be one or two-sided? We can test many different types of hypotheses. We can test superiority. Is one treatment better than the other? Non-inferiority. Is one treatment as good as the other? Or non-inferiority, no worse than another. Or equivalence. Is one treatment about the same as another? And these are all valid statistical tests. How you do it is different depending on the hypothesis and the form of it. And there's many approaches. And so the appropriate one, and I put ones because there are often many different ways to test the same hypothesis, many different statistics that can be used. And so, but they all depend on the underlying properties of the data. And so it's really important to understand what the data are like and then to be able to match the analysis to them. Now, I tell my students often that you can go up and down the hall with the same data set in our Department of Biostatistics and ask each of the faculty, how would you analyze these data? And you might get different answers from every faculty member because there is no single rule about how you analyze data. And it's often a frustration. I mean, our students get really angry when I say, I don't know, how do you think you should do it? Do you think that that's an outlier? Do you think you should remove that data point? Because there aren't necessarily hard and fast rules in most of statistics. So there are many appropriate ways to analyze data, and so that's one of the decisions that have to be made in designing a study. Okay, so as I mentioned, I'm going to go through 3 studies from the literature and talk about some of the properties and what some of the choices they made are, just to give some context about clinical trials. This is something that's been in the news a lot lately, this idea that this was a randomized trial of peanut consumption in infants at risk for peanut allergy. So this, and I want to have a disclaimer, I'm not an expert in any of, well, in most of these, in the first 2 of these studies, I wasn't involved in them, I just pulled them from the literature and read the papers, same as any of you would. And I'm not a clinician, so some of the underlying clinical details may go past me. So this was a study in the UK that was interested in evaluating whether consuming or avoiding peanuts until 60 months of age is most effective in preventing the development of peanut allergy in infants at high risk for the allergy. So these were kids that already exhibited some property, such as eczema, or something that classified them as high risk for having a peanut allergy. And so this goal of this study was to determine whether avoiding or consuming peanuts before 60 months of age is most effective in preventing development of an allergy in infants. Okay, so we're going to go through and see what we identify as each of these key features of the study. So what would you think is the primary outcome in this study? Peanut allergy, right? And whether or not they develop a peanut allergy by 60 months of age. So I would phrase that as a statistician as the proportion of participants with peanut allergy at 60 months of age. So what type of data is this? Is it continuous? Is it, what type of data? Sorry? Categorical, right, it's binary. It's nominal. So we have yes or no, and there's no, well, we could order it if we wanted. We could probably classify it, but there's no logical ordering to the categories. Is this objective phrase as a one-sided or two-sided hypothesis? This is kind of a tricky question because they don't really come out and say, I would claim that this was a two-sided hypothesis. They're saying that whether or not consuming or not consuming has a higher proportion of peanut allergy. So I would say this is a two-sided hypothesis. Okay, so this is a tough question. What would you think might be the appropriate analysis for comparing proportions? This may be, I mean, I know the detail with which you've had these statistics lectures is not that great, so I'll give you this. This is a chi-square. So a chi-square test of association would be used to compare the proportions. So this, when I look at just the objective of this study, before I read on, this is kind of how I view it in my mind. These are the key features of the study. So now we're going to look at what they actually did. See if it matches with what we or I think they should have done. And remember, just because if it doesn't mean it's not right. It just means there are other intricacies in the data that maybe I didn't know about. Okay, so let's start with a little bit more about the study. The study population were infants with severe eczema, an egg allergy, or both. So there was some reason to assume that they may be at a higher propensity towards having allergies. The infants were all aged between 4 months and 11 months, so before they hit that 1 year mark. And then remember, we're looking at what happens at 60 months, which is 5 years. So this is a longer term follow-up for the study. So the study design was as follows. The participants were randomized in a stratified fashion. So the paper refers to this as 2 cohorts. They did a skin prick test. And if it was negative, then they randomized them to receive either peanuts or no peanuts. If it was positive, then they also randomized them to receive peanuts or no peanuts. But they did this within the context of these 2 separate strata, okay? And there's a lot more detail in the study. For instance, within the positive group, they also did a more complicated allergy test, and they threw out people who already were exhibiting allergy to peanuts. So that aside, they stratified their randomization. So why do you think they might have stratified? Does anyone have any thoughts or suggestions for why they might have stratified their randomization?
They can balance the groups on things so they don't have to necessarily control them in their analyses.
Right, so that's exactly why we randomize, right? We randomize in a study so that we can balance our groups between all of the observed and unobserved factors that could confound the relationship between our treatment and our outcome. But why might we stratify that randomization?
For clinically important factors, you don't want to impact the outcome.
Yeah, so it's similar to the answer of, we want to have balance, but in this case, this skin prick test might tell us who might have a higher propensity towards having an allergy. So if you have a positive skin prick test, then you might be more likely to have an allergy. So to ensure that we're not confounding this result by that, they stratified. And stratification is a very common technique in randomized trials to further account for having another factor that you think is strongly related. Oftentimes we might stratify for age and onset of a disease, for instance, because people with earlier age of onset may have more severe disease, and we want to make sure that we can detect effects that are due to the treatment and not due to this stratification variable. Okay, so as we're all probably aware, no single study collects just one outcome. So in this study, we talked about the primary outcome was the proportion of participants with peanut allergy at 60 months determined by means of an oral food challenge. So they fed them peanut butter to see if they had a reaction. But there were several secondary outcomes, including skin prick tests for peanut allergies and serum biomarkers of the allergic response. So you're looking at like histamines and histamine blockers and that sort of thing. Clinical trials nowadays, especially large trials, are notorious for collecting a lot of data. And so it's really important to designate what data being collected are primary and secondary, and to be really careful of how we treat those outcomes. Okay, so let's see. We talked about what the hypothesis was, what the outcome is, the analysis. So analyses were performed on each strata independently. So I mentioned that they had these 2 strata, they called them cohorts, and they analyzed them separately so that they didn't have this confounding due to a propensity towards allergy. They used the intention to treat principle to do their analysis. Does anyone know what intention to treat is? Everyone. It's you analyze as randomized, essentially. So even if a kid was randomized to the peanut group, never ate peanuts, and the whole time they should have been exposed, they'd still be analyzed as if they were in that group. They also did per protocol analyses secondarily. So per protocol analyses are only including those who followed their protocol. So this wouldn't include if someone was in the peanut group and didn't eat peanuts. They would not be included in that analysis. If someone was in the no peanut group but ate peanuts, they would also not be included in those analyses. Okay? There's other analyses like as treated, where you might include those not in the group they were randomized to, but what they actually got. That's another type of analyses. Most clinical trials do intention to treat, and we can have a full day-long debate about whether that's appropriate or not, but that's what's done most of the time. Her protocol is often done as a more confirmatory analyses secondarily. As we discussed in the beginning of this, the primary analysis was a chi-square test of association, so they did what I thought I would have done. And they had no description in their analysis section of the paper. They actually had no description of how they analyzed the secondary outcomes, which I thought was interesting. My experiences are that journal reviewers nowadays for large clinical trials really won't let you get away with that, so I was kind of surprised. So I'm going to go through the results now just so we can talk about what happened. So the cohort 1 was a skin prick negative test. So these were kids that didn't exhibit a propensity towards towards an allergy. 530 of 542 were included in this intention to treat analyses. Those 12 were excluded because in further testing, they were already showing that they had peanut allergies. So it's not ethical really to give kids peanuts if they already have a peanut allergy. So those kids were excluded. So what they found was actually fairly striking, and it's getting a lot of press. I heard about it before I found the paper. 13.7% of the avoidance group developed an allergy versus 1.9% of those that consumed peanuts. So by age 60 months, there was this difference of an absolute difference of 11.8% with a confidence interval of 3.4 to 20.3%. So what we'd be looking for is this difference different than 0? And that confidence interval doesn't overlap 0. We also have a p-value that's quite small. But if you've been keeping up with some of the discussions going on in Nature and some psychology journals, I'm not sure if I should be even reporting p-values anymore because we're going through a phase where p-values are bad. Okay, so anyway, this was a very striking result. This was in the first cohort. In the second cohort, they also saw a similar trend. In fact, it was more striking. And in this group, there was a 35.3% rate of or frequency of allergy in the avoidance group, and a 10.6% in the consumption group, who were allergic to peanuts at 60 months. And the difference was almost 25%. And the confidence interval, again, fairly wide, but not overlapping 0, with a highly significant p-value. So their conclusions were that early exposure to peanuts resulted in a significantly lower proportion of children with peanut allergy at 60 months of age. I think the data fairly well support that conclusion, but there are several items that need to be addressed to ensure that we believe these results. So the first is adherence. So adherence is how well did the families really take the treatment, which was consuming the peanut butter. And so in order to really interpret the results in the context of the efficacy of the intervention, we really need to understand the adherence. And in fact, they showed in the paper that the adherence was pretty high. What about dropouts? How many kids did they lose by the end of the study? And again, in this study, it was pretty low. They had a low dropout rate. And we always have to wonder about safety. So were there any safety issues? So of course, people who developed a peanut allergy early on, they discontinued treatment, right? If they were allergic to peanuts and they were randomized to the consumption group, then they discontinued in consuming peanuts, but they were counted as an event. They had an allergy. But safety runs the gamut. In some studies, safety issues, and we'll talk about this in some other studies, could be death. In some, they could be mild issues like bruising from having your blood drawn. So safety is a big concern in all studies, and we'll talk a lot more about monitoring safety, but we have to take it in the context of each study. And then the other two aspects of a study that you always need to consider when you're assessing the results is the validity and the generalizability. So what's the validity? So how well does the study design really show that the results are valid, right? So is there a good design?
Good internal.
Oh, yes, there's good. This study, I think, has good validity. I agree. I think randomized trials are considered the gold standard. They well describe their methods if you read the paper, and it seems like they were on the up and up in terms of their study design. It's got good validity. What about generalizability? What's generalizability, first of all?
How well it can be applied to a broader population or a population.
That's right. So so can we take our conclusion and apply it more broadly than just to the study sample? And so in this, I would say that they have decent generalizability. I mean, we're looking at generalizability to people of, or infants of that age group. So that's early exposure, but obviously that's what they were testing. So that makes it. So I would say that this, I thought reading this study, I would encourage you to do so, it was a good study. It was well written, and it had good generalizability, it had good validity. They addressed these issues in their manuscript. So I thought this was a good study, a good example to use. And it's always fun to look at studies that are being given press, because oftentimes what the press is saying is not concordant with what the study actually says. Okay. So the next study we're going to look at is a JAMA paper that came out last year, and it's looking at the title is the effects of high versus low glycemic index of dietary carbohydrate on cardiovascular disease risk factors and insulin sensitivity, the Omnicarb randomized clinical trial. So this one's a little bit more of a mouthful, and I found it to be a little bit more difficult to try to explain, and we'll see in a minute. So their objective, and actually JAMA papers are great because the objective is stated front and center in the abstract. So their objective, as they've described it, is to determine the effect of glycemic index, an amount of total dietary carbohydrate, on risk factors for cardiovascular disease and diabetes. Okay, so the first thing I want to point out in their objective is they are looking at two things, right? They're looking at glycemic index and total amount of dietary carbohydrate, okay? And then their outcome, according to this, we'll get there. Okay, so what's their outcome? Risk factors. So the way that it's described in their objective is very broad. They say it's risk factors for cardiovascular disease and diabetes. As you read further in the paper, their primary outcomes are, there's more than one. It's insulin sensitivity, and that is the area under the curve of glucose and insulin levels during an oral tolerance test. So they're looking over time, they're measuring the levels, and then they're taking the area underneath that curve. They also are looking at LDL, HDL, LDL and HDL cholesterol, triglycerides, and systolic blood pressure. So three cholesterol measurements, not surprising for a dietary study, and then systolic blood pressure. So those are their risk factors for cardiovascular disease and diabetes. So what types of data do we have here? Continuous, right? These are continuous data, presumably normally distributed, which would make life happier and easier, but not necessarily. Did they frame this as a one- or two-sided test? Two. They very clearly said the effect of. So they didn't say our objective is to determine if a high carbohydrate diet is better than a low carbohydrate. And so what's an appropriate analysis when you're dealing with normally distributed or continuous data? A t-test, right? A t-test or a regression model. In the case of a clinical trial, oftentimes a simple t-test is okay because you have balance between your factors and you don't need to control for them. So it's why I love clinical trials. It's so simple. Everything's so simple except for everything but the analysis. Okay, so it's true. I'll show you the third example, and then my Dsmb example comes from a trial I worked on, and I'll talk about some of the complexities and the studies. The best laid plans of mice and men often go astray, okay? And that's true in life, and it's true in clinical trials. Okay, so this study population was overweight adults with systolic blood pressure between 120 to 159 millimeters of mercury. And I should say that this was a study done in two centers. It was done at Harvard and Hopkins in their clinical research centers. So the design is actually quite complicated. I'm presenting it in a little bit of a simplified manner. It's a randomized crossover trial in which participants were given 4 complete diets, consisting of their meals, snacks, beverages for 5 weeks. Patients were randomized to a sequence of diets. So they were randomized to a sequence of 4 different diets, and they chose 8 possibilities. So what they were looking at, and I wish I could laser, oh no, it doesn't work. High definition. So I apologize to the camera. What they're looking at was some combinations of high and low carbohydrates and high and low glycemic index. And if you look at all the different ways you can combine those 4 boxes and all the ways you can have 4 different diets, there's actually 24 different possibilities for a randomization scheme for each person. What they chose were 8 of these possibilities out of those 24 for different reasons. And again, if you're interested, I would recommend reading the paper. So this is called a factorial design, where you have 2 arms that you're looking at, and you're looking at the combinations. And factorial designs are done for 2 reasons, and I'll talk more about them. But one is to be able to detect an interaction. Do you think that the difference between high and low carbohydrates might be different for diets with high and low glycemic index? So that's one reason you might do a factorial design. And in fact, that's the only way you can really detect an interaction appropriately. Another is to be able to test 2 interventions simultaneously you get more bang for your buck, because if you don't think there's an interaction, you can have the same sample size for both of these 2 arms of your study, and you get to do 2 tests at the same time for the price of 1. So that's really the 2 reasons why a factorial design is employed. But this was a weird situation, because this was a factorial, but then it was also this crossover. So a crossover design looks like this. For each person, they had an 8-day run-in where they were given the diet to see whether they were going to adhere. Then they had a 2-week washout period where they could eat whatever they were usually eating. Then they were given their first diet of these, and so what they would be randomized to is a sequence. They would get a sequence of 4 diets. And so for each person, their sequence is predetermined. And they're going to do each diet for 5 weeks, and then have a 2-week washout period where they get to eat whatever they want, and then the next diet. And so this is a little bit of a different type of study now, where you're looking at changes within a person. And now I just gave away why you might do a crossover. What's the benefit of a crossover?
Your own control.
Get to look at changes within a person. That's right, your own control. Each person is their own control. So you have the benefit of knowing, if I'm your participant, what my systolic blood pressure is before the study started, and then at each of the diets. And you can know that, you can presume, you can't know, you can presume that any changes you might see might be due to the diet, because I'm the same person. I'm not changing, presumably, anything else about me. Okay? So that's the benefit of a crossover design. And crossover designs often are used in smaller studies. They're often used in feeding studies. I've been working with some investigators. Crossovers are often used where a lot of external factors may impact individual changes as well. Okay, so in this study, as I mentioned, there were 5 primary outcomes. Insulin sensitivity was measured via the glucose tolerance test, and it was measured at 0, 10, 20, 30, 60, 90, and 120 minutes. So if you plot those out and then you take the area under that curve, that's their primary, one of their 5 primary outcomes. And then systolic blood pressure, LDL, HDL, and triglycerides. Their secondary outcomes included diastolic blood pressure, fasting and 2-hour blood glucose and insulin, and other lipoprotein parameters. And so they actually had many secondary outcomes. We'll talk about the fact that they had multiple primary and secondary outcomes in a few minutes. Okay, so despite all of the diets considered, their primary analysis was to compare the high, so high carbohydrates and high glycemic index, to the low diet. That's the low carbohydrate and low glycemic index, using a t-test for mean within person changes. Okay? Since outcomes are normally distributed, the approach makes sense for each of these changes, for each of their outcomes. But they're losing a lot of information by doing this. So one of the benefits of crossover design is you have these repeated measures on an individual, and you can take advantage of that by using more complicated models. So this is a case where where I might have used a repeated measures type of model to look at these differences. And that would allow me to look at all the different diet combinations in a single model rather than individual t-tests. So, and they again don't provide any description of their secondary analysis or secondary outcomes, which was, again, is surprising. But I think the assumption is their approach was going to be similar to the primary outcomes. Yeah.
Sorry, just a slight segue. What are your thoughts on using something like linear mixed models for this? Because it's not really used a lot in literature, like utility acceptability.
And it's not used a lot in what?
It doesn't seem to be used very much in the literature yet, even though it's probably a much better way of testing something like this.
So I would say it is becoming a lot more common depending on the type of data you have. In epidemiologic research, mixed models are used a lot. And, you know, I think there's becoming a paradigm shift because we're collecting more data and we're collecting it over time. And there is this realization that you're losing information if you don't analyze it over time. Right, right. I mean, and they're losing information here. You're losing that. You are getting some of that within person variability captured when you do a change. That paired t-test does account for that in some, but because we have these repeated measures, you can get better estimates of that within person change and better test these contrasts. So, but I do think it is becoming more common, and I think on my soapbox, I think it's becoming more common that research is much more collaborative, and clinical trials, especially larger clinical trials, are no longer able to be funded unless they have a collaborative team that often includes a statistician. And I think that is helpful in trying to move forward some of these methods. But again, it's not. There's no single right way, and so oftentimes we do what people are most comfortable with too. Okay. So here is the results of the primary outcomes. And so let me orient you to what's in this figure. So each of these tree diagrams is a different outcome. So we have insulin sensitivity, triglycerides, HDL, LDL, systolic blood pressure, and diastolic blood pressure. And then each of these sort of rows in that tree diagram represent a comparison. So remember they said that their primary comparison was the low versus high. So that's the one at the very bottom. But these other comparisons are shown in this figure as well. So the first one would be low glycemic index, high carb, high glycemic index, high carb. It's not clear that all of these comparisons are important, but I think they felt since they did all of these diets, they might as well show them. And so what we're looking at here is the difference between the two diets. And so if they're different, then if they're significantly different, then we would expect the confidence interval not to include 0. And so 0 is in the middle of each of these figures, and the dot represents the difference, and the bars around that dot represent the confidence interval. So what we're looking for is differences all to one side of this line, either side. And so what we see, the only outcome that exhibited a difference is triglycerides. And I don't think that they put p-values, but the confidence intervals are actually fairly far from 0. They're looking at the mean in triglycerides of about 15 or about 25 points, and the upper end of the confidence interval is around 15 for their low, high comparison. So of all of their comparisons that they did, only one outcome shows significance, and it's significant on a couple of different diets. Okay, so we'll come back to this in a second. We'll talk about what their conclusion was. So they said that diets with low glycemic index compared to high glycemic index did not result in improved insulin sensitivity, lipid levels, or systolic blood pressure. Okay, so let's go back here for a second. And so they're making a broad statement about their results, that overall they didn't see real differences. Would you agree with their statement? Yeah, I would. I would say that, well, we'll talk about the multiple testing issues, but they saw a difference in one place here, but it's really in the context of the larger diet, they were aiming for these 5 outcomes. And to really say that there's a difference, I think they need to see more than just one of them really changing relative from one diet to another. Diet studies are really, really hard. They're really, really hard. I'll give them that. So again, there's some items we need to be aware of when we're interpreting these results. So the first is adherence. Oftentimes in dietary studies, they're given food diaries and told to write down everything that they eat, and that's how we measure adherence. In this situation, they were actually given the food. So I think that, and I can't remember I have the paper, but I can't remember from the paper, I think their adherence was actually a little higher than most diet studies because they gave them the food. The validity, again, is a question. I think this was a decent study. Again, there were 24 different possibilities they could have randomized to, and they only chose 8. But I think that's okay. I don't think we would have needed all those comparisons given the 24. Generalizability, I think, is actually not so great in this study. They had a very specific population of overweight people with relatively well-controlled blood pressure. So that's not necessarily who your typical overweight person is. We have a lot of overweight people with uncontrolled blood pressure, and then they also did this in very specific places in the country where I don't remember what their diversity was, but we may not have the most diversity in their sample. The big issue in this paper that I found when I was reading it was the issue of multiple testing. So I think one of your lecturers talked about how the number of tests you do that are not that are on the same data increases your likelihood of making a type 1 error. And so in this case, they've done, well, just in this figure, they've done 6 times 5, 30 different tests on these same data, and they didn't control at all or count at all for their multiple testing. And so interpreting these results, I think also we have to do so in the context of multiple testing. And is it possible that these significant results we saw were type 1 errors? And it is. It's not beyond the realm of possibility. So I agree with their conclusions, especially in light of the fact that they did all of these tests. And that's just their primary outcomes. Okay? As a grant reviewer, I often bring that up as a weakness in grants about people at least acknowledging that they're doing multiple tests. So I don't necessarily think if you have one primary outcome and a lot of secondary outcomes, I don't necessarily think you need to adjust for multiple tests. And this is actually an area of research for me, so it's something I'm familiar with and know quite well. But you at least need to acknowledge that you are doing multiple tests, and so perhaps on all those secondary outcomes, they're more exploratory, and that you may need to be aware that there could be type 1 errors. Okay. I should have asked, are there questions about this study before I move on to the next? Yeah.
So my question is, as a statistician, when you work with these groups doing these trials that have a lot of data, and you're writing it up for publication, and there's obviously a word limit on the journal, how do you come to a compromise in terms of the level of detail that you're able to present the data? And are a lot of the journals willing to work with you in terms of supplements? And I read clinical trials all the time. It's like I know they have this data, and it's not in this paper.
Yeah, that's a great question. So primary outcome papers, we usually just stick to the primary outcome. And then we definitely include a lot of supplementary tables, and we really try hard to publish other papers that show those other data. But you're right, it is difficult, especially many journals now have, besides word limits, they have a lot of requirements for what you have to report. So you have to report how your power calculation was done, and you have to report certain details about the study design, and that leaves you less space to report outcomes. So it is definitely a challenge, and certainly, and I'll show you the next example, talk a lot more about because it's a study I was involved in, and I'll show you and talk to you about what we are doing now as opposed to just what's in this paper. That's a great question, though. I mean, there's a lot of, and there's a lot of room for choice in that too, right? So how do you decide what goes into the paper? And we are all ethical, and we all want to present both sides of the coin, but oftentimes the inclination is I'm going to present what results are significant because that's what I have room for, and that's more interesting. And so that's a difficult dilemma. Yeah.
That and multiple other reasons is why I think it's a bit of a push now towards people to positive data, or at least moving towards that.
That's right, and especially, I mean, NIH requires it now, and other agencies are moving towards that as well. Okay, the next study is a study published in the Lancet in 2013. It's the blood pressure targets in patients with recent lacunar stroke, the secondary prevention of small subcortical strokes, or SPS3 randomized trial. Randomized is spelled the British way there, because it's a British journal. So the objective in this paper was to determine whether treating blood pressure to a lower target, less than 130 millimeters of mercury, lessens the rate of stroke recurrence compared with a higher target, 130 to 149 millimeters of mercury. Okay? So, as I said, I've been involved in this study quite closely. So I'm going to talk about it. I'm going to try not to talk too much about it so we have time for the Dsmb part. But let's go through, based on just the objective from the paper, what would you say the primary outcome was? You remember? Stroke recurrence, right. So the rate of stroke recurrence. So again, this is a different type of outcome. Now I can tell you, I purposely picked these 3 papers because they each had different types of outcomes. What's the type of data? This is a little bit more tricky. This is a rate. This is a time to event outcome. So we're actually analyzing the time until somebody developed a stroke, a second stroke, or was censored. Was this framed as a one or two-sided hypothesis? One, right? It was framed as one-sided. Okay, and I'll tell you up front, we did not analyze it that way. So given that it was a survival or time to event outcome, what's the appropriate analysis? A log rank test or some sort of survival analysis. So the typical approach is to do a log rank test and then also to do a proportional hazards model. And so we actually did a proportional hazards in this case. Okay, so the study population was patients age 30 or older who had had a recent, within 180 days, MRI-confirmed lacunar stroke. So these were patients who were all very well characterized on MRI and all had very specific, you all probably know more about than I do, stroke subtypes that are milder strokes. So these weren't big strokes. They were relatively small strokes. And the functional status of the patients is pretty high when they have these small strokes. This study took place in 81 sites in the U.S., in Canada, Latin America, and Spain. Okay? So the design, again, is a 2x2 factorial design with patients randomized using a permuted block design. So this paper was the second in a series of 2 primary results paper. We actually had, again, a factorial design as in the diet study. We were looking at antiplatelet therapy. This was a combination of aspirin and Plavix, or clopidogrel, versus aspirin alone. And we were looking at blood pressure control, usual versus intensive target. So the goal was to identify whether either of these treatments prevented recurrent stroke separately. We didn't feel there would be any interactions based on what was in the literature when the study was designed, and so we didn't power it to detect an interaction, but rather to examine these 2 separate treatment effects differently. The rationale for the blood pressure controls, the guidelines suggest that lowering blood pressure below 150 in patients with lacunar stroke, but there was no evidence of how low you should go. So we wanted to see whether or not lowering it even further was better than just lowering it to between 130 and 149. So patients were randomized to one of these 4 treatment cells, so some combination of aspirin and clopidogrel or aspirin and blood pressure control, and then in a permuted block design. So a permuted block design says that we're going to randomize patients in certain blocks of a certain size, say 4. And so if we think of these as A, B, C, D, let me use a block size of 8. We might do A, B, C, D, A, B, C, D. Then the next block, we would permute how that is ordered, and we might do B, A, C, D, B, A, C, D. And then the next block might be A, A, B, B, C, C, D, D. So each block has a different ordering of the treatments. Okay? Does that make sense? Okay, so my gray bubble. Why might you use a permuted block? Any thoughts? So I should have told you the blood pressure arm was unblinded. So the investigators knew which blood pressure target they were trying to lower patients to. So you might use a permuted block so that you can't predict the next randomization. Because if a patient walks into your clinic and you see that they had a little bit more severe stroke, you might say, I don't want to randomize you because the next patient's going to the higher blood pressure target group, and I think it would be better for you to go to the lower. And so a permuted block eliminates that bias that might enter into a study based on knowing what the next treatment is. It just eliminates that ability to predict the next treatment assignment. Okay, so in SPS3, the outcomes, the primary outcome was recurrent stroke, and that was either hemorrhagic or ischemic. It was a composite. And secondary outcomes included MI, major vascular events, which was a composite of MI, stroke, and vascular deaths, and then death. This was an interesting study because, again, I'm going to get way off topic with this one because I know it so well. I've lived it for a long time. So treating with clopidogrel and aspirin is known to increase the risk of hemorrhage. So while hemorrhagic stroke was a primary outcome, it was also one of our safety outcomes in this study. Okay, so our primary analysis was a time-to-event analysis. We used Cox proportional hazards model. And our secondary outcomes were assessed in the same fashion. And because I wrote the statistical methods for this paper, I know that both of those are in there, and it's described in the methods section. Okay, so that didn't show up very clearly. I apologize for that. This figure shows the probability of patients experiencing a primary event by time after randomization. So what we see in this figure, and again, I apologize to the camera that I'm wandering, is this is time 0, and time in years since randomization is increasing across the bottom of the page, the bottom of the figure. The y-axis is then the probability of a primary event. And so the blue line here is the higher blood pressure target, and the red line is the lower target group. And so our hypothesis was the lower target group would lower stroke more. So what we would expect to see, if it were true, is that this red line would be statistically significantly lower than the blue line, okay? And what we're seeing in the bottom here is the number at risk. So at the beginning of the study, we had 1519 patients randomized to the higher group and 1501 to the lower group. And then as time went on, we have fewer patients. And that's not because we had a lot of dropouts, but we had staggered entry into the study. So everyone had at least approximately 1 year in the study unless they had an event or dropped out for some other reason. And then you can see as time went on, we had only 40-some patients at 8 years. So those were our people who were with us from the beginning and stayed with us, and that's great. I mean, it's great, but we don't have a lot of information at 8 years. And so do you think that there looks like a lot of separation in those lines? No. There doesn't look like it, but that's why we do statistical tests, right? We do statistical tests because our eyes can't really tell us whether or not there really is a difference. And so what we found in this analysis, the hazard ratio is 0.81. Okay, so that indicates that those in the lower group were 20% less likely to have an event than those in the higher group. And we're looking at this to be different from 1. If the rates were the same, then fraction representing the ratio would be 1. And so we're looking to see if our confidence interval includes 1. And in this case, it was 0.64 to 1.03. Okay? And so it includes 1. And in fact, our p-value was 0.08. And so, God says 0.05 means statistically significant, right? And so if it's above 0.05, this is not significant, right? Well, this was a matter of some debate. Our clinical investigators felt that this was enough to show a trend in the right direction and that perhaps 0.08 wasn't too far from statistically significant. We, as statisticians, our statistical group felt very strongly that this was not a statistically significant result because we had done multiple tests, right? We'd done a test looking at the antiplatelet arm. And then one of the things I'm going to come to when I talk about Dsmbs, we've done a lot of interim analyses. We looked at these data considerably during the course of the study because of some of the safety concerns. So in light of all those analyses, we as the statisticians were like, I think it's a stretch to say that this is close to significant. And in fact, the paper originally was submitted with a much stronger conclusion than what was eventually drawn, which is that lowering systolic blood pressure to the lower target resulted in non-significant reductions in the rate of all stroke. So it's true, right? It's a non-significant reduction, and it's true it's close. It is true that it's close. But there are a lot of things that happened with this study, like we did a sample size re-estimation. So partway through the trial, we started seeing published in the literature stroke rates that were much lower than what we had used for our power calculation. So we asked NINDS if we would be allowed to look at our stroke rate in our study and figure out what our power would be if that stroke rate continues at the end of the study. And it turned out that the power would be too low to detect the difference that we wanted to detect. And so the NINDS allowed us to do what's called a sample size re-estimation partway through the study. So the planned sample size for SPS3 was 2,500, and we ended up collecting 3,020 patients. And so we even increased the sample size to try to show a significant result, and still didn't. So in light of that and many of these other things, we had a hard time feeling like this was a significant result or suggestive. And I was comfortable with the wording in the conclusion, that it's a non-significant reduction. Yes?
Since you're involved in this study, what were the discussions around potentially having a person of 1 millimeter mercury difference falling into one group or the other?
That's a really good question. So the intention to treat analysis looked at the group they were randomized to, not what their actual achieved blood pressure was. And so that's a great question. We're still working on those analyses to try and figure out. So SPS3 was a very busy study. We took blood pressure measurements every 3 months. So trying to even define what's their achieved blood pressure has been difficult. What we did find is it took about, in both groups, took about 6 months to lower blood pressure to their target, and that about 80% of the patients in the higher group and about 70% in the lower group stayed in target most of the study. So they were in target, and the ones in the higher group that didn't stay in target often were because they were below target. So physicians were not comfortable taking them off drugs to have their blood pressure go up. And so those were counted as out of target. So that is a great question of how does their actual blood pressure reflect their propensity towards having events. And we're working on those analyses right now. Hopefully those will be coming out in the next couple of months. Yeah?
A question about the data used for your power analyses. It's in all disclosure related to something I'm working on right now. And my question is whether you should use published literature to look at, differences in this case, I guess it's the incidence of stroke. My particular study I'm looking at is the results following a certain intervention, or should you look at your local data to make those?
That's a really good question, and most of the studies that I've been involved with are powered based on published literature, and particularly published clinical studies. And I'll tell you why. We often see lower event rates or better outcomes in clinical research than we do in clinic as a whole, because people, with all due respect, people often get better care in a clinical trial. I mean, this group, if you think about this group, they were coming in the clinic every 3 months. Their blood pressure medication was adjusted every 3 months, or sooner if their blood pressure was uncontrolled. They had regular communication with the study coordinator. They weren't just coming in annually to see their physician. Now, that being said, if you're proposing something more pragmatic, where you're wanting to see what really happens, so this would be an efficacy trial. If you really want to look at effectiveness, then I think using data from the clinic is more appropriate, because you really want to see what happens in the true population, right? Does that help answer your question? And it's true. I mean, there's been research showing that the rates of secondary strokes are decreasing over time in clinical trials. But it's a lot harder to get at that in large populations in clinics. So not necessarily. I was going to say often in clinical research you get a larger sample, but that's not always true. There's a lot of smaller studies published as well. So some of the other discussion items, so I mentioned the antiplatelet arm that we did multiple testing. This was a case where the hypothesis was framed as one-sided, but we actually did a two-sided test. And the reason for that is, again, very infrequently do we actually do one-sided tests in clinical trials. So the supposition was that that lower would be better, but there was no evidence of that anywhere, really, to warrant doing a one-sided test. Question, do we need to interpret the results in the context of the antiplatelet arm? So maybe for people on combination antiplatelet therapy, we saw a different effect than for people in the single or monotherapy. So that would be the interaction between the two treatment arms. And we did look at that, and there was no significant interaction. So then there's the question of validity, and I like to think, having been involved in the study, that it's highly valid. I'll tell you that with most clinical trials, there are lots of issues. We did a lot of monitoring, looking at people's blood pressures to try and understand if they're too good. Are people reporting blood pressure that's too good? And in fact, we found one site that was. And so we had to deal with how to manage that the site was not putting down the correct blood pressure data. So there are those issues. And they do arise, and I know I've work on several multi-center trials, and there's a lot of site monitoring that goes on, but I don't think it's unusual to have little issues like that. And we looked at whether that impacts the results, and they don't. And there's generalizability. And so we have a very broad population. We had about 16% African American, about 25% Hispanic or Latino, and we had a broad population from the U.S., Canada, Latin America, and Spain. So I think we had some decent generalizability within the scope of who we studied. So within the scope of people who have lacunar strokes. Okay, not generalizable to people who have intracranial hemorrhage. Okay, so the antiplatelet arm was stopped early due to safety concerns coupled with an apparent lack of efficacy. And if you pull the antiplatelet arm trial results, there's a huge lack of efficacy. This decision was made by the Data and Safety Monitoring Board, the Dsmb, for SPS3. So this was a group of specialists that was appointed by the NINDS, and it consisted of experts in stroke, statistics, and hypertension who were not directly involved in SPS3. And so that leads us to DSMB. So I'm going to talk about DSMBs now. I want to take a short break, right? You usually take a short break. So let's take about a 5-minute break, and then we'll come back and we'll talk about DSMBs.
Hey, how you doing?
Doing well.
Good. I'm enjoying your talk.
Thank you.
I have another specific question I wanted to ask you. What do you think about clinical trials where you evolve from like a phase 2 into a phase 3?
Adaptive.
Yeah,
it's becoming a lot more common in a lot of fields. I think I'm a proponent of it if it's done well and if it's well thought out, because you use those data to inform your phase 3 and increases your sample size, frankly.
yeah.
As long as the trick is to make sure that you're not making big changes to the protocol and that you're not making big changes to the study design going to phase 2.
Yeah. I proposed something to the phase 3 clinical trial, which is pretty a little bit ambitious for somebody with not a track record except for some pharma studies, and they've expressed some doubts about, I mean, can you really do this? Can you really treat your patients? You know how to do things and whatnot. They proposed doing like a pilot study and then go there. But the thing that bothers me about it is that that's really like probably, if you do the math, probably a 5-year delay.
Yeah.
And one of the things we've been talking about is, hey, what if you did like, you're to a phase 2, and then if things are panning out, you can evolve right into a phase 3.
So I know in NINDS, they really like that. I don't know what field are you in?
It's a cancer study,
Okay.
liver
So I
cancer.
don't know, I don't do much cancer research. I'm not familiar with how NCI is viewing those, but NINDS loves the adaptive designs right now, and they're really proponents of implementing that. So basically you have to, I mean, the difficulty is you don't know if it's going to go on, you don't know what, if you should budget for the full study or just the phase 2, and so the difficulty is logistic and working with the agency to make sure that if there's some promissory note that you see positive results, will continue to fund you. That's logistically what makes them, I mean, that's what I think is keeping them being used for. It's just logistically difficult. It's hard to, when you do a powered population, you can describe what you think the scenario will be, but when you're doing adaptive design, you have infinite number of different scenarios that could happen, and so trying to figure out what might happen and describe that in grants is really tough. And so those are the types of issues I don't think the gains from them have been shown in a lot of places to be enough to warrant the headaches that come with the other aspect.
Yeah, I guess in my case scenario specifically would be that if it's just not panning out, that then you would just kind of truncate it after the two as opposed to moving into the larger phase 3.
Right, but so that's the easy case, because what you do then is easy. It's you shut down the study, you stop the funding, you close it out. But if it goes on, typically it won't just go on for 2 more years of a 5-year period. So how do you obtain funding to keep going? You have that, you have to have some grants, and have to be reviewed again,
Thank you very much.
Oh, you're welcome.
No, you're fine. Sorry, I won't be able to say after. I had a Dsmb question that's like super specific to me, so I don't know that we would talk about it.
Okay.
So, so like I have a AKA award, and the study that I'm doing in it is, it's weird because like it would be considered like if it were like a big study, it's a RCT,
Right.
and it would be, I guess, a phase 3 one, but it's very small, and so it would be phase 3 in that the device that I'm using has already shown efficacy and safety and all that. So there is a little bit of gray area there, and so in all my summary statements, my notice of award, it's like DSMB. So I proposed a Dsmb just to be safe, and they're like, Dsmb was proposed although not required. And then when I submitted my IRB to UAB, again, because it was just so far in advance and I just wanted to cover all my bases, I proposed one. So, I guess what I'm wondering is, like, to me, it makes the most sense to just have a DSMP in place for if there's an adverse event, and then we can convene. Do I have to have a DSMB that meets before it, or?
If you're going to have a DSMB in place, I would have it meet and understand the study in case something does come up. A lot of those types of studies have just a safety monitor. And oftentimes it's the PI. So
which would be,
if safety issue comes up, then they evaluate it, they send it to the IRB, and they
let everybody convene at that point.
But it never hurts to have it. I'm on DSMBs where I rarely hear anything.
I guess right. And I invited all these people to be on there. At this point it's been a year, and like I've scheduled my first participant for Friday, and I was like, holy crap, I forgot that because for me, I just kept thinking about it like worst case scenario we would meet, and then I realized that the language was that we would meet before it started. But they've seen my research plan,
and that's the benefit is it's kind of like in a way get an external advisory committee, looks at your research and suggestions, helps you unbiasedly decide is recruitment progressing as it should.
Right. Okay. So I guess long story short, it is kind of a gray area, kind of depending on what type of funding you have and stuff like
and
that.
what the scope of the study is.
Right. Okay, thank you.
You're welcome. Oh, yeah. Yeah.
I remember mentioning your name under your husband.
Yeah, that's right.
We did that.
Yeah. What's your name? Tom. Tom. Right. Nice to meet you.
Over there. Well, y'all have fun.
All right, I think we'll go ahead and start back up. I know a few people will filter back in, but we'll go ahead and start back with DSMBs. And so this part's a little less interactive, so maybe I'll just call out questions randomly as we go along, just to keep you awake. DSMBs, Data and Safety Monitoring Boards, are given the responsibility of monitoring, accumulating data during studies. And there's a long history of utilizing DSMBs in trials sponsored by government, and pharmaceutical industry is using them more and more. And in fact, almost exclusively, pretty much every device or new investigational drug study now has DSMBs. So what is the purpose? Why do we have DSMBs? The primary responsibility of the DSMB is to protect the safety of the participants. And so DSMB is an external committee charged with doing so because investigators are in natural conflict of interest. So we, as investigators, we have time and energy and effort and sweat, sometimes blood, and oftentimes tears vested in the study. So this has been a labor of love. We've been working on it, and we want it to continue, and we want to see an outcome that we think might happen. In addition, we're being paid to do this study. So it's in my best interest to keep the study going as long as I can because I'm going to keep getting paid as long as the study's going on. So the Dsmb is there to review efficacy and safety data and to protect the safety of the participants, but also to ensure the credibility of the study. So I talked about validity in the first half of the lecture, and the Dsmb, one of their charges is to help ensure the validity of the study by making sure that the study's done in a good fashion. Okay, so why do we have DSMBs? Again, it's required of all multi-center trials that are run by NIH and by the VA, and the specific requirements vary by institute. So some people, in some studies, it's okay to have an independent safety monitor. Some studies, the safety monitor is the PI, depending on the scope of the study. Some studies, I'm involved with studies in psychology here at UAB, where the studies have local DSMBs. They're all experts from on campus. And then SPS3, as I mentioned, it was 5 experts. There were 2 statisticians, 2 neurologists, and a hypertension specialist, none of whom are here, none of whom had any involvement in SPS3. So DSMBs take a broad array of formats. FDA requirements require ongoing safety monitoring in clinical trials, but DSMBs are minimally addressed in these government regulations. So they specify that there needs to be monitoring. DSMBs are only required if mortality or major morbidity is a primary or secondary endpoint. And there's a draft guidance. I don't understand. I've never understood. The FDA calls all their guidance draft guidance, and it very rarely becomes a real guidance. I don't know. But it's a draft guidance that was developed in 2001 about DSMBs, but it's only required for morbidity or for mortality or major morbidity outcomes, okay? That doesn't necessarily mean that that's only required by NIH in those specific situations. Okay, so DSMBs have 2 main charges. Remember, their primary goal is to assess safety, but they also have the responsibility to monitor efficacy. So efficacy is the assessment of whether or not there is a meaningful difference in the primary outcomes of the study. And so why is it important to monitor efficacy? Well, perhaps you have a placebo-controlled trial, and so half your patients are getting this new treatment, and half are getting nothing at all. And if we see a big difference between outcomes in these 2 groups, it's not ethical to keep giving placebo to those patients. And so we want to make sure that we're treating these patients ethically. And so the Dsmb is responsible for helping to do so. Safety involves all other aspects of differences between groups and adverse outcomes. Okay, so focus and safety is on monitoring adverse events. So remember in SPS3 I said that that hemorrhage was both a safety and efficacy outcome. So it was well known, if you pull up the label for clopidogrel, I'll get there. Okay, so the Dsmb is responsible for assuring that participants are not exposed to unnecessary or unreasonable risks. For those of you who have submitted grants to the NIH, you have a human subjects section, and you have to talk about what the risks are and why they're not unreasonable or unnecessary. And the Dsmb is responsible for assuring the study is conducted according to high scientific and ethical standards. That's that validity piece. Okay, so all trials need monitoring, but not all trials need Dsmbs. And as I mentioned, that there's different forms that monitoring can take. It may be desirable to have a Dsmb if the trial involves highly experimental therapies. So you may not know what to expect. That might be a good time to have a Dsmb. If the trial involves substantial risk to study participants, so in SPS3, we suspected, based on what's known about Plavix, that there might be risk of hemorrhage, so it's important to have a Dsmb. If your trial involves particularly vulnerable study populations, such as children or persons with impaired ability to consent, so you might be doing traumatic brain injury research, and patients might come into the ED and not be able to consent themselves, then that might be a good case when you might need a Dsmb. And any trial, as I mentioned, where it's ethically important to stop if the primary question is definitively answered. And by definitively answered, I don't just mean that we saw increased efficacy. We could have already answered the question, there's no difference, and it's not ethical to continue in that case as well. And this is true even if there are secondary questions that are not fully answered. Okay, so the first principle of DSMBs is their responsibilities. And so this is again, reiterating that this is important. DSMBs are a hugely important part of a study. So the primary responsibilities are safeguard the interests of the study participants, preserve the integrity and credibility of the trial in order that future patients might be treated optimally. So we want to be able to use these results to make decisions in future patients and ensure that definitive and reliable results are available in a timely way to the medical community. So we want to get those results out there. The DSMB has a role in that as well. So the DSMB should have a multidisciplinary representation, and there should be experts in different specialties as well as in statistics. So it depends on the trial, but different trials require the inclusion of other disciplines. So in many trials include patient advocates. So that would be someone who has the disease and can speak about what the real issues are from a patient's perspective. And this is especially true with the advent or the recent excitement around patient-centered outcomes. So if you're doing PCORI or patient-centered outcome research, then it's in fact required that you have a patient advocate on your DSMB and that you have patient involvement in the trial. Ethicists. So I have a study I'm involved with that's an observational study, and we have an observational study monitoring board, and we look at cognitive functioning. And there are a lot of questions about reporting cognition by race. And so we brought an ethicist into the observational study monitoring board to give their input on this issue. The appropriate size of a DSMB is different depending on the type and of the trial and the type of expertise needed. So I work on some school-based studies in the Lung Health Center I have in the past. We always have representatives from the school involved in those. So that would be different than if I'm doing a stroke trial, we probably wouldn't have a teacher on our DSMB. Typically, either the study sponsor appoints the DSMB. So if you're doing a phase 3 multi-center trial that's NIH sponsored, they will appoint your DSMB for you. If you're doing a small study in a single site, then you might get to choose your DSMB for you. The studies I'm involved with in psychology, we choose our DSMB, and it's usually just 3 people, and we meet very informally. Our reports are pretty short, as compared to the multi-center trials where we give the DSMB a book every time we meet. And then this is a big issue and something I think that is not happening as often as it should, but there need to be training programs, or there need to be training for people who are going to be on DSMBs. How do you know what a DSMB should be doing if you've never done one before? I'm involved in the Society for Clinical Trials, and one of the things we've been doing is trying to do more workshops about DSMBs. And there are books out there, and there are different forums for learning more about it. Okay. So anyone who's doing any research at UAB knows about conflict of interest, and conflicts are an important part of a DSMB. One of the goals is try to eliminate important conflicts of interest. And so these are not just financial, but intellectual and regulatory as well. So the most obvious are financial. If you're being paid by a drug company as a consultant for a different drug, you probably don't want to be a DSMB for a new drug. And as we know from if you've done conflict of interest for UAB, if your spouse or your significant other or your father or your dog is on the board for some drug company, then you probably shouldn't be on a DSMB for one of their studies. But it's really, really impossible, I think, to eliminate all conflicts of interest, either real or perceived. And we talk a lot about perceived conflicts of interest because it's a small world. The community of scientists is really small. I mentioned I do a lot of stroke studies, and I am involved with NINDS for reviewing their clinical trials for all their neurologic diseases. The number of statisticians that do neurologic diseases is very small. It's a small world. So now I want a DSMB for someone who now I'm also on the committee for one of their graduate students. So is that a conflict of interest? What about when I'm reviewing their grants now? Is that a conflict of interest? So it's a really fine line, and NIH is really struggling with this as they're starting to do more networks where there's these big networks of investigators from across the country that are all involved in these clinical trials. And then you get a new one. How do you get someone to review that? They're probably somewhere involved or collaborate with someone in the network. So defining conflict of interest is really, really difficult. And so the minimum criteria is that you're not involved in the study, you have no history collaborating with, and you're not from the same institution as the investigators. Now, I will say that no history of collaborating with, I think, is kind of gray as well. And in a lot of cases, when you're working on a trial, you sometimes will work very closely with the Dsmb. I had worked very closely with the SPS3 Dsmb because of many of the safety issues that arose. And so now I know the statisticians. Well, one of them was one of my professors when I was getting my master's, but the other one I know quite well just from working with him regularly. So it's really, really hard to define these lines. Okay, so the fourth principle is confidentiality. So oftentimes when you're on a Dsmb, you'll see data that tell you something about what might be going on in that trial. And oftentimes the only people who will see that are an unblinded study statistician and the Dsmb. And so the Dsmb has a responsibility to maintain code of confidentiality, to discuss, to be aware of what they can discuss with investigators and what they can't. And also this comes up as a conflict for financial reasons as well. If you're doing a pharmaceutical trial and you're on a Dsmb and you see some interim results, you can't use that to your own gain. Okay, so several different types of meetings occur with Dsmbs. So before recruitment begins, there's always an organizational meeting. It's important to introduce the Dsmb members to each other and to the study investigators. The Dsmb has a responsibility to review the study protocol and to review the quality control procedures. And there needs to be some discussion about what the reports to the Dsmb will contain and what they'll look like. And so all of that takes place before the study even starts. Then the Dsmb, most of the time, Dsmb meetings are scheduled on a regular calendar schedule, every 6 months or, 6 months. Every 6 months, every other meeting would be face-to-face versus on the phone. But there are specific things that need to be brought up at these meetings. One is early safety and early trial integrity reviews. So early on, are there any glaring safety events that are happening? Also, is recruitment going way more slowly than was planned? Are patients dropping out really quickly in this early set of patients? So there are items that a Dsmb needs to review early on. And so this is sometimes a struggle. So I'm on a Dsmb where we saw a safety signal very early on. And the issue is when you don't have a lot of data, it's hard to know how certain that effect you're seeing is. And so this is a dilemma. Do you keep going and see if there's more safety issues, or do you stop and make modifications early on? Then the committee needs to meet and discuss formal interim efficacy analyses, if these are planned. Not all clinical trials do efficacy interim analyses. There are often trials that have low risk, or there are other reasons why there may not be an efficacy analysis. And then end of trial debriefing. So at the end of the study, the Dsmb usually sees the results before they're published or presented, and they usually see a draft of the paper that's going to be submitted just to give some input if they agree with how the investigators are presenting the results. It's a kind of a insulated peer review, if you will. Okay, so at each meeting, each Dsmb is different, but in general, these are the different things that the Dsmb will review. The performance of the trial with respect to recruitment, follow-up and retention, protocol adherence, and data quality and completeness. So our SPS3 Dsmb report showed recruitment figures and recruitment by site. Are there any sites that are recruiting slowly? It showed our demographics. It showed it overall and by treatment arm, blinded. So they didn't know who was in which arm, but they could see if we were getting balance or not in our study characteristics. We showed percents in target for each of the blood pressure targets. We showed study compliance for the antiplatelet arm. And then we showed visit completeness and data completeness. So in SPS3, we had a pretty intensive protocol. People, as I mentioned, came back every 3 months. So we showed how many people were coming back to their visits, and then we showed how how many of those forms were entered when they should be. So how on time was the data entry? The Dsmb will review and consider any protocol modifications or any ancillary studies to make sure that these aren't going to negatively impact the main trial. So yes?
So is being a Dsmb member a paid job or a volunteer job?
That's a great question. It's typically you get paid for your service, but it's a minimal amount. You know, it's a consulting fee.
What kind of time does it usually take?
It depends on the study, and I should say, if you're doing it for NIH, it's a small fee. If you're doing it for industry, it's considerably more. It depends on the study. So I'm on DSMBs where we literally just meet every 6 months or even less frequently, and we get the reports and everything's fine. The DSMB where we had that safety issue, for about 3 months, it took a lot of my time. We had a lot of calls. We talked with the investigators frequently. But studies that are going smooth, just like any study, if it's going smoothly, it takes less time. If it's got issues, then it takes a little more. So in SPS3, we had protocol modifications. Originally, our minimum age was 40, and recruitment was a little slower than we had anticipated, so we decreased it to 30. We also had ancillary studies. We had a biomarker study that was looking at biomarker levels and whether that was associated with stroke outcomes. And then at the end of each meeting, the DSMB presents a report to the sponsor, whether it's a drug company or the NIH, to determine whether the study should continue as planned. Excuse me. Did I skip one? No. Okay, so a typical agenda for a DSMB might look like this. So they start with a closed executive session. That's when just the DSMB members come together and discuss what's in the or they start with conflict of interest. Like any NIH meeting, the first thing you do is discuss conflict of interest. And then they review the agenda and whether they have any additions to the agenda. So they receive the report ahead of time and they've reviewed it. And then they may have additions to the agenda because of something that was caught their eye in the report. And then they have an open session with the investigators. So the investigators come in and you do a dog and pony show. You talk about what's going on in the study. You present the trial progress. You talk about how everything's going swimmingly, and you're so glad to be doing this trial. And so then they kick you out, and they talk about the closed report. And so this is when only the unblinded investigators. There's usually a statistician who doesn't know the treatment assignment and a statistician who does. And that unblinded statistician participates in the closed session. The closed session then is the safety report that can be by treatment and can be unblinded depending on what the DSMB has decided. Sometimes they'll see A and B, sometimes they'll see aspirin and clopidogrel and aspirin and placebo, depending on what they've decided ahead of time. And then they'll review interim analyses. The reason the unblinded investigator is important to be there is they've got insight into the study that they can provide that maybe isn't clear just from looking at the data. And then they kick that person out, or those people, and then they go back into closed executive session. So then they discuss everything they've seen in the data, both in the open and the closed, and what recommendations they're going to make. And then this can vary, but they'll have another open session with all the investigators, and they'll discuss their recommendations. Now, in my experience, if there's lots of crazy things going on, then after that closed executive session, they often invite the unblinded investigator back to have more discussion. So depending on what's going on, this will deviate, but this is the general idea. Okay, so that's what the DSMB perspective is. Now, if you're presenting a DSMB report, what might you put in it? So the first thing that goes in your report is a letter to the DSMB that's just outline, or that contains an outline of the study. So the best thing I receive when I'm on a DSMB, my favorite thing is a summary of the protocol, a one-page figure that describes, because I'm not doing the study day to day. So I can't remember exactly what's going on with this protocol. And so to get this, and I don't want to pull up the 40-page protocol and review it all. I mean, frankly, I'm busy and I'm lazy. So I like to receive a one-page summary of what the study design is. Then, actually, I should have flipped these. The first thing I usually include is a letter to the DSMB that is a summary of what they're going to see. So going through each section, recruitment and retention, and highlighting for the DSMB what they're going to see in the report. And it's not meant to pick and choose, but really just to make it easier for the DSMB to navigate the report. Then you'll have information on patient screening. How many screens did you do? How many failed? How many did you recruit from that? Then you might have study accrual. So you might have a figure showing study accrual over time, or you might have a table that shows it by site. You'll have eligibility violations. How many people did you enroll in the study that didn't actually have a lacunar stroke? Or, oh, you found out afterwards the person was 28, not 30. So how many eligibility violations? Then you might include baseline characteristics. In SPS3, we showed gender and race and baseline blood pressure. Those are the things we are interested in at baseline. You might have adherence to medication schedule. So pooled by treatment, though. So when you're doing the open report, everything is pooled by treatment so that there's no way that the Dsmb or the investigators can discern which treatment is which, unless the Dsmb requests it otherwise. You might have follow-up data. You have treatment and study status. You'll have dropouts. Those sorts of managerial items will be presented in this report. There won't be anything in the open report that represents outcomes or safety events, though. Okay? The closed report will start off similarly. You'll have an executive summary, again, explaining the key issues. And then you'll have, then it's good practice to include what's the interim monitoring plan that was agreed upon so that the Dsmb can be reminded of this. And then the summary of the closed report data that was presented at prior Dsmb meetings. So what did we see before up to this point, or what were some of the discussions that were had? There might be repeat information from the open report now by treatment group. This is where the Dsmb gets to see how these differences are playing out by treatment. There may be analyses of secondary and primary efficacy endpoints. So that might be your futility or your efficacy analysis. You may have some subgroup analyses, and you might adjust some of your analyses for baseline characteristics. It really, really differs depending on what the Dsmb has decided they want to see. And it changes over time. We had some issues that came up during the course of the study that really changed our Dsmb reports. A closed report will always have adverse events and safety data. And again, how the Dsmb wants to see that will differ depending on the Dsmb. Some studies will present each patient and every single lab value at every visit for that patient. Some will do it in summary. It really depends on what the issues are and what the data can tell you. You might have information on discontinuation of medication. So how many patients are still in the study being followed but maybe stopped their medication? How many dropped out? This is differ by treatment arm. How many crossed over to a different treatment is important as well. Okay, so it is really important that information presented in the closed session not be revealed to the study investigators except as explicitly authorized by the Dsmb or by the study funding agency. And the reason for this, the reason that the interim analyses are blinded to the study investigators is because knowledge of emerging trends in the data may impact how they influence or how they enroll patients or how they manage the study. Maybe consciously or not consciously, but still may have impact on their practice with the study. And so we're trying to eliminate biases. Now, I think that sometimes this gets taken to more extreme than it maybe should, but the reality is we are trying to eliminate any biases from knowing what treatment effect might be happening and trying to influence that. Okay. So if the Dsmb has determined any of the following, they may recommend that the study be terminated, suspended, or amended. So if they happen to see that the study has answered the primary study question, that is, they've shown a treatment effect, they might stop early. If they see that the study is futile or will not be able to determine that there is a confirmed decision at the end of the study, they might stop. So this is called a futility analysis, and there are statistical means by which you can say, at this point, is there any chance we'll see a difference at the end of the study? And if the probability of that is quite low, then the Dsmb might stop for that reason. If the Dsmb feels that there's ethical violations or that there's not good scientific practice going on, they may stop the study early. Or if the Dsmb determines that the treatment or the study itself poses any unreasonable or unnecessary risk to participants, they may also stop early. Yeah?
Point A, how do you reconcile that with power analyses and that idea that you really should stop studies when you find a positive effect because it could just be a supplement?
Again, there are ways to show statistically that it's highly unlikely that it's due to chance alone, and that regardless of what happens the rest of the study, that there would be that difference there. So there are statistical means for determining that. But there's always, even if it's very low, there's always still a chance of a type 1 error. So in our primary efficacy analysis, we usually use a 0.05, right, as our alpha level. For efficacy interim analyses, we often use something very small, like a 0.001. And so that helps us control that sum. But you're right, we can never really fully control that. Okay. At the end of each meeting, the Dsmb then makes their recommendations to the study sponsor. So they either say, great, let's keep going as we're going, don't make any changes. We want to continue this study, but we want the protocol to change to reflect that people only with systolic blood pressure under a certain amount should be enrolled, or the study should be stopped for some reason. In addition, then, the Dsmb will give a report back to the investigators, kind of a debriefing to discuss, hopefully not just areas of concern regarding safety and performance, but also things they're doing well. And then thereafter, the Dsmb provides a written summary on the board's recommendation. And so, as a statistician, we received 2 summaries from the Dsmb. We got the closed report and the open report. Our clinical collaborators only got the open report. Okay. So that's kind of the broad, what does the Dsmb do, and what are the issues the Dsmb is dealing with. I want to now enlighten you to some of the statistical issues that might come up on Dsmbs. So Dsmbs are generally charged, as I've mentioned, with stopping studies for efficacy, for futility, for toxicity, or for just poor study management or recruitment. And so the decision to stop a trial early is complex and requires not just statistical judgment and not just clinical judgment, but a marriage of the two. And in fact, it's not just clinical judgment, but it's also study management judgment. There's a lot of issues with stopping studies or changing studies, and so that there's a large impact on that as well. So non-statistical reasons that a study might stop early include logistical or data quality problems that are so severe that you can't correct them. So perhaps you're supposed to have patients come back every 6 months and nobody is. Well, then you're not getting the data you need, then maybe you should stop the study. There may be some new trials, new evidence that emerges that make the study not scientifically valid or important anymore. And in fact, that happened during SPS3. There were other studies that emerged showing results of combination antiplatelet therapy that we had to make an argument to the Dsmb why it was still ethical and safe for us to continue to do this in lacunar stroke patients. Perhaps the enrollment is so slow that the study will never finish, or at least not finish in a reasonable amount of time. Or you might run out of resources, which is unfortunate, especially if things are going quite well, but that unfortunately does happen. There may be statistical reasons for stopping early as well. So perhaps there's statistically significant differences in the rates or the frequency of serious adverse events in the 2 groups. And in fact, the active group has a higher frequency or rate of that event. So that might be a safety issue, and you might stop for that reason. There might be greater than expected beneficial effects. So oftentimes if we see efficacy at an interim time point, the difference we see is larger than what we powered the study for. And so large, in fact, that we're willing to say that without seeing any more patients, it's clear that there's a statistically significant difference. Conversely, the statistically significant results at the end of the study are just not likely. It's just not possible or very highly unlikely that even if we collect the rest of the patients, that what we're seeing now is going to improve. And so this requires that interim looks be taken at the data. And there have been many, many statistical methods developed for monitoring data in clinical trials to minimize the role of subjective judgment. So remember, we looked at that figure and we said, are those 2 lines close enough together or far enough apart? And we can't determine that by eye. So we need statistical tools to make these decisions. Okay, so some of the drawbacks to early stopping, so we might make a decision based on a single endpoint, and that compromises the ability of the trial to evaluate the overall risk-benefit ratio. So we can't make inference about other outcomes because we won't have observed them to the full extent of the study. We might lose important long-term information. So perhaps we can get this in SPS3, we might see whether or not there are differences in stroke, but one of our secondary outcomes was to follow people to look at changes in cognition over time. So if we stop early, we might not be able to ascertain cognitive assessments over time. And this may require additional trials to address questions that haven't been answered because we've stopped early, particularly in secondary outcomes. So for instance, the cognition outcome is a great example. If we really want to know if the combination antiplatelet therapy is effective for helping to prevent stroke or for helping to improve cognition over time, we might have to do a whole other trial to ascertain that. So how you monitor your data depends on the goals of the trial. Some clinical trials don't have any interim monitoring, while others have very stringent interim monitoring plans. And you can build in flexibility into the monitoring plan, both in the timing and the number of interim analyses you do. And so many of these, as I mentioned, there are several different interim monitoring tools that have been developed statistically, and each of them has different properties for doing more or less, or being more or less flexible in your design. And so early on, the Dsmb and the study investigators should determine what the appropriate monitoring plan is. Okay, so under the null hypothesis, if there's no difference between groups, as we've already discussed, repeated testing at a specific alpha level inflates our probability of saying there's a difference when there may not be. And so even with 5 to 10 tests, we can have a serious misinterpretation of the results. So as you can see in this table, we only do one test, we set our alpha level at 0.05, then we have 5% chance of making a type 1 error. But as we increase the number of tests, that increases, and it increases considerably. So the solution is to adjust our alpha level in each of our individual tests so that our overall significance level is maintained. So you can do that in a number of ways. And so I mentioned a few minutes ago that we might do our final test at the 0.048 level, and then our interim test at 0.02, or 0.002, excuse me. Okay, so we might split up that alpha so we use some of it in our interim testing and the rest of it at our final test. And there's numerous ways to do that, and some of them are listed there. And how you choose depends on what your goals are. Okay, so before deciding to terminate the trial, there's a lot of things that need to be considered, such as, are there prognostic factors at baseline that might help explain some of these differences? How will you include missing data? Will you be impacting the internal consistency of the trial? What are the outcomes from other trials that are similar? And what is the impact of this early termination on the credibility and acceptability of trial results? If you stop a 1,000-patient trial after 50 patients, nobody will believe that you're really seeing what you're seeing. So how will this impact how your results will be viewed? Okay. So I'm going to talk about SPS3 again in a little bit more detail and a little bit more of our experience. And I know we don't have a lot of time left, so I'll do this a little quickly. So as I mentioned, there were two arms. There was a blood pressure arm and an antiplatelet arm. And we had this, so the paper I use as an example focused on the blood pressure arm. I'm going to talk a little bit more about what happened in the antiplatelet arm, because this is a little bit more interesting in some ways. So again, this arm was randomizing patients to aspirin alone versus aspirin plus clopidogrel, so dual antiplatelet therapy versus mono antiplatelet therapy, and it was a double-blind placebo-controlled trial. It was monitored by, as I mentioned, a 5-member Dsmb. Dsmb meetings were scheduled originally twice per year, but early in the study, the Dsmb noticed a trend towards a higher rate of hemorrhage in one of the two antiplatelet groups. So this was blinded, they didn't know which, but it wasn't unexpected because the risk of hemorrhage is considered a known side effect of antiplatelet therapy. And in fact, if you pull the package insert from Plavix, it talks about the risk of hemorrhage. So what we were looking at was whether or not the difference in rates exceeded that would be expected. So we knew what to expect in monotherapy, and we wanted to know, were we getting a rate of hemorrhage above and beyond what we might expect. And so the Dsmb asked the Statistical Center, my group, to increase the frequency with which we monitored events in that arm. And so every 3 months, we presented them with reports about safety. Further, even complicating things more, early in the study, conditional power, which is a futility analysis, suggested that it was really unlikely that by the end of the trial, we would see a difference in the treatment arms. So very early on, with less than a third of the patients, we could see this trend. But it was still really early. So before I get to what happened, so this trend continued. And every time we presented them with an interim analysis, we saw again that there was an increased risk of hemorrhage and that there was little likelihood that we would see a difference at the end of the study given what we've observed so far. And every Dsmb meeting we would go, that we have a team of statisticians, we would talk beforehand and we'd say, this one, they're going to stop this arm. How are we going to deal with this? What are the changes we need to make to the forms? What are the changes we need to make to the data entry system? What are the changes we need to make to the protocol? What are the changes we need to make to the IRB? Every study, we prepared ourselves for the worst, because the worst for study management, perhaps the best for the patients. And every meeting, it didn't happen. So 6 months before the study ended, we had a Dsmb meeting, and they chose to shut down the antiplatelet arm at that point due to increased risk of death among those in the dual antiplatelet therapy arm. So although this risk of hemorrhage was there and was big, and although it was unlikely we were going to see a difference at the end of the study, the Dsmb was okay continuing the arm because we knew there would be this risk of hemorrhage, and it wasn't bigger than what we would expect. But they started to see a twofold risk of death among those randomized to the antiplatelet arm, randomized to the dual antiplatelet arm relative to those in the monotherapy arm. And so even though there were only 6 months left in the study, the Dsmb felt that ethically they couldn't continue to randomize patients to this arm. And so 6 months left, they shut down this arm with the blood pressure arm continuing. And so all of the logistical issues that I just mentioned had to be implemented at that point, right before study closeout. So why would the Dsmb terminate that arm with so little time remaining? What do you think? I mean, I kind of mentioned it, but why would you as a member of the Dsmb feel it was your responsibility to do that?
Risk is greater than potential leverage.
That's right. The risk was just so great that they couldn't ethically continue, even for 6 months. Now, there are a lot of cases of Dsmbs being sued and study agencies being sued because these risks were observed and study wasn't stopped. And so there is this fear and concern among people on a Dsmb that they want to be more conservative, that they do want to make changes if they're seeing suggestions of these because of protecting themselves and the agency. And so I mentioned, what are the implications of terminating a study or arm? There's just, in addition to having to notify the patients that the study was terminated early and why, there are huge implications for study management. And so dealing with those are considerable. I'll just leave it at that. Okay, so in conclusion, I'm going to give just some overall statements. They're kind of like a tale of two parts here, but clinical trials vary greatly in the approach to answering the questions of interest. So different designs are appropriate for different questions. We talked about just 3 that I pulled from the literature, all that had not just a standard 2-arm placebo-controlled design. Each of them had some nuances. And all of those determinations really depend upon the question that's to be answered and how the best way to do so might be for that particular study. Ensuring the analysis, I would be a bad statistician if I didn't hammer the point home that ensuring that the analysis is appropriate for the type of data is essential for having valid results, okay? The question you want to answer has to be able to be answered statistically, and the methods you use have to be appropriate for the data you have. And the results must be interpreted in the context of the study population. So remember, on each of those 3 studies, when I presented the conclusions, I also talked about what some of the issues might be that we should further consider. Not just the results of the statistical test, but was there validity and generalizability? Did they do multiple comparisons and not account for them? Was their population biased for some reason? So what are some of the methods they use and what are some of the limitations of the data? Also talked about Dsmbs. And so Dsmbs are responsible for ensuring the ethical conduct of a clinical trial. And the number 1 responsibility is really ensuring patient safety. Dsmbs review data on study progress, patient characteristics, safety, and the logistical, clinical, and statistical issues all play roles in decisions made by the Dsmb. So nothing's done in a vacuum. So if you have any questions, I'm happy to take them now, or if you want more information, here's how you can contact me, and thank you for your attention, and I appreciate it. Are there any questions either here, or I know there's people watching from elsewhere? Yeah.
You mentioned lawsuits, which I'm assuming is quite rare.
I'm sorry.
You mentioned lawsuits, which
Yeah.
I'm assuming is quite rare, but sitting on the Dsmb, are you personally liable? How's that work?
That's the question that isn't quite clear. And so I think there are some cases where they've shown that the Dsmb themselves aren't liable, that the sponsoring agency would be, but I'm not exactly sure. There are books about that like the ethics of clinical trials and that sort of thing. Other questions? Yeah.
Are there established Dsmbs here that you would even use for small impact trials?
I don't believe so. I think that there are probably resources through like the CCTS or other avenues to help you identify people to be on Dsmbs, but typically it's not like the IRB that's a static body. They're typically more dynamic. Sure. Other questions? What are people on the web? Hello, are you awake? Do you have questions? All right, well, thank you again. Please feel free to contact me if you have questions. Oh, you know what? They might not have been able to ask questions.
I can put out that one.
Okay.
Yeah. I'll press stop recording.